Did you know that hemorrhagic strokes, though less common than ischemic strokes, are responsible for nearly half of all stroke-related deaths? What makes these brain bleeds so rapidly devastating? And why do their outcomes remain so poor despite advances in modern medicine? In this video, we unravel the hidden dangers of intracerebral and subarachnoid hemorrhages, conditions that can turn silent risk factors into life-threatening emergencies in a matter of minutes. Now, before we begin, this video is for educational and informational purposes only and is not intended to replace professional medical advice, diagnosis, or treatment. Always seek the guidance of a qualified healthcare provider with any questions you may have regarding a medical condition. Hemorrhagic stroke. Hemorrhagic stroke represents one of the most catastrophic events in clinical neurology, accounting for approximately 10 to 15% of all strokes, yet contributing disproportionately to stroke-related mortality and long-term disability. Unlike ischemic strokes, where a blocked vessel restricts blood flow, hemorrhagic strokes result from a ruptured cerebral vessel, leading to bleeding directly into the brain tissue or subarachnoid space. The global burden is alarming. Studies estimate that over 3 million cases of intracerebral hemorrhage occur annually worldwide, with mortality rates ranging from 40 to 50% within the first 30 days. Survivors often face severe neurological deficits, making hemorrhagic stroke not just a medical emergency, but a significant public health concern. Subarachnoid hemorrhage, though less frequent, carries a similarly grim prognosis, particularly when due to ruptured aneurysms, where even prompt surgical intervention may not prevent death or debilitating outcomes. The suddenness, unpredictability, and severity of these events underscore the critical need for awareness, rapid recognition, and immediate management. In this commentary, we will explore the underlying mechanisms, risk factors, clinical manifestations, diagnostic approaches, and the latest treatment strategies for both intracerebral and subarachnoid hemorrhages, providing essential insights for healthcare professionals and caregivers alike. Signs of hemorrhagic stroke. Imagine this. A middle-aged man is sitting at his desk when, without warning, he clutches his head and exclaims, "This is the worst headache of my life." Within moments, he becomes confused, slurs his speech, and collapses. By the time emergency services arrive, he is struggling to stay conscious. Could this be a hemorrhagic stroke? When it comes to hemorrhagic strokes, whether intracerebral or subarachnoid, the signs are often sudden, severe, and impossible to ignore. The most distinctive symptom, particularly in subarachnoid hemorrhage, is what patients frequently describe as a thunderclap headache, a rapid onset, explosive pain unlike any headache they've ever experienced. This should immediately raise red flags for clinicians and bystanders alike. In intracerebral hemorrhage, common signs include abrupt weakness or numbness, often affecting one side of the body, difficulty speaking or understanding speech, sudden visual disturbances, loss of coordination, and altered level of consciousness. Seizures, nausea, vomiting, and stiff neck can also occur, depending on the location and extent of bleeding. These signs are not subtle, and they demand urgent attention. A delay in recognizing these red flags could mean the difference between survival with recovery and permanent disability, or even death. Here's the takeaway every healthcare professional and layperson must remember. If someone develops a sudden, severe headache or abrupt neurological changes, especially after trauma, hypertension spikes, or in those with aneurysm risk, assume the worst. Call emergency services immediately. In stroke care, every minute counts, and with hemorrhagic strokes, time lost is brain lost. Causes of hemorrhagic stroke. Why does a blood vessel deep inside the brain suddenly rupture without warning? What makes some individuals ticking time bombs for a hemorrhagic stroke without ever knowing it? Consider this real-world scenario. A hypertensive patient ignores his medication for months, believing he feels fine. One day, after a stressful argument, his blood pressure spikes and an already weakened artery bursts, flooding his brain with blood. In that moment, years of uncontrolled hypertension culminate in a catastrophic intracerebral hemorrhage. The leading cause of intracerebral hemorrhage is chronic hypertension. High blood pressure slowly damages small penetrating arteries, weakening their walls until they can no longer contain the pressure. This silent process may continue unnoticed for years before ending in disaster. Other causes include cerebral amyloid angiopathy, common in the elderly, which results in fragile, amyloid-laden vessels prone to rupture. Trauma, such as head injuries from falls or accidents, is also a major culprit, particularly in younger individuals or those on anticoagulant therapy. Blood disorders like hemophilia or thrombocytopenia, as well as excessive use of blood-thinning medications such as warfarin or novel oral anticoagulants, further raise the risk. For subarachnoid hemorrhage, the most frequent cause is the rupture of a cerebral aneurysm, a balloon-like bulge in an artery wall that can burst under pressure. Arteriovenous malformations, AVMs, though rare, are another structural defect that can lead to spontaneous bleeding. Other contributors include heavy alcohol consumption, smoking, illicit drug use, especially cocaine or amphetamines, and genetic predispositions, all of which can weaken cerebral vessels over time. And here's the memorable lesson for every patient and clinician alike. Control what you can. Manage blood pressure relentlessly. Screen high-risk individuals for aneurysms or vascular malformations when indicated. And never ignore warning signs, because when it comes to brain hemorrhage, prevention remains far superior to treatment. Symptoms of hemorrhagic stroke. What happens when the brain suddenly drowns in its own blood? What does the body reveal when such a silent catastrophe unfolds? Picture a woman at home who suddenly drops her coffee cup, her right arm limp and unresponsive. As her family rushes to help, they notice her face drooping on one side, her speech slurred and incomprehensible. She tries to stand, but collapses, confused and unable to move her leg. These are the alarming first signs of a possible intracerebral hemorrhage. The symptoms of hemorrhagic stroke depend largely on the location and size of the bleeding. In intracerebral hemorrhage, the bleeding occurs directly into the brain tissue, causing a sudden onset of focal neurological deficits. These may include sudden weakness or numbness of the face, arm, or leg, typically on one side of the body, difficulty speaking, dysarthria, or understanding language, aphasia, a loss of coordination or balance, visual disturbances such as double vision or complete vision loss, altered level of consciousness ranging from confusion to deep coma, seizures, which may be the first sign in some patients. In subarachnoid hemorrhage, the hallmark symptom is a sudden, severe headache, often described by patients as the worst headache of my life. This may be accompanied by neck stiffness from meningeal irritation, photophobia, sensitivity to light, nausea and vomiting, loss of consciousness in severe cases, seizures or focal neurological deficits if the bleeding is extensive. What makes hemorrhagic stroke particularly dangerous is that its symptoms can mimic those of an ischemic stroke, yet the treatment approach is vastly different. Rapid, accurate recognition is therefore essential. Here's the critical takeaway for all healthcare providers and bystanders. If anyone exhibits sudden weakness, slurred speech, facial drooping, or a thunderclap headache, call emergency services immediately. Time is not on your side, and quick intervention could mean the difference between recovery and irreversible brain injury. As we delve deeper into the complexities of hemorrhagic stroke, it's crucial to stay informed, not just as healthcare providers, but also as members of the community who may one day recognize these life-saving warning signs in others. If you find this information valuable and want to stay updated on the latest in stroke care, neurology, and emergency medicine, consider subscribing to this channel. Your awareness could make the difference between life and loss for someone in need. And don't forget to share this video, because the more people understand the signs of stroke, the more lives we can collectively save. Diagnosis of hemorrhagic stroke. How can clinicians quickly distinguish a hemorrhagic stroke from an ischemic one, when every second of uncertainty risks permanent brain damage or death? Picture this. An elderly man is rushed into the emergency room, unconscious after collapsing at work. His blood pressure is dangerously high, and his pupils are uneven. Is this a clot blocking his brain's blood flow, or a ruptured vessel spilling blood into delicate brain tissue? The answer will determine whether he receives life-saving treatment or a catastrophic, misplaced therapy. The first and most essential step in diagnosing a hemorrhagic stroke is neuroimaging, typically a non-contrast CT scan of the head, which can quickly and reliably detect fresh intracranial bleeding. CT scans are widely available, fast, and remain the gold standard for initial evaluation. Bright hyperdense areas on the scan confirm the presence of blood within the brain parenchyma, suggesting intracerebral hemorrhage, or in the subarachnoid space, indicating subarachnoid hemorrhage. In some cases, if the CT scan is inconclusive or further vascular detail is needed, such as in suspected aneurysms or arteriovenous malformations, a CT angiography, CTA, or MRI/MRA may be performed to identify underlying vascular abnormalities. Lumbar puncture can also be useful if subarachnoid hemorrhage is suspected but not seen on the initial CT, revealing xanthochromia in the cerebrospinal fluid. Laboratory tests, including complete blood count, CBC, coagulation profile, and toxicology screens help assess bleeding risk, coagulopathies, or substance-related causes. Electrocardiography, ECG, and chest imaging may also reveal systemic contributors like cardiac sources of emboli or hypertension. Time remains the most critical factor. A delayed or missed diagnosis can lead to inappropriate therapies such as thrombolytics, disastrous in hemorrhagic cases, or irreversible brain damage. And here's the essential advice for every clinician and emergency responder. Always scan before you treat. Never administer clot-busting medications until a hemorrhagic stroke has been ruled out. Early imaging saves lives and guides the right treatment pathway, preventing fatal mistakes in those precious first moments. Treatment plan for hemorrhagic stroke. What happens after the diagnosis is confirmed? Once bleeding in the brain is identified, what can be done to stop the damage and save a life? Imagine a young woman collapses at work with sudden loss of consciousness. In the emergency department, a CT scan reveals a ruptured cerebral aneurysm causing a subarachnoid hemorrhage. Her life now depends on swift, decisive action by the medical team. The treatment plan for hemorrhagic stroke focuses on three crucial goals: controlling the bleeding, reducing intracranial pressure, ICP, and preventing further complications. For intracerebral hemorrhage, immediate blood pressure control is essential. Elevated systolic pressures, typically above 140 to 160 millimeters of mercury, must be carefully lowered using intravenous antihypertensives like labetalol or nicardipine to reduce the risk of ongoing bleeding while maintaining cerebral perfusion. Patients on anticoagulants require urgent reversal of coagulopathy. Vitamin K, fresh frozen plasma, or prothrombin complex concentrates, PCC, may be used depending on the agent involved. Platelet transfusions are considered if thrombocytopenia or antiplatelet use is present. Neurosurgical interventions, such as craniotomy for hematoma evacuation, are reserved for select cases, especially when large bleeds cause mass effect, brainstem compression, or worsening neurological status. For subarachnoid hemorrhage, the priority is securing the source of bleeding, usually through endovascular coiling or surgical clipping of the ruptured aneurysm. Delayed cerebral vasospasm, a serious cause of secondary brain injury, is managed with nimodipine, careful fluid balance, and sometimes balloon angioplasty. In both types, intracranial pressure monitoring, management of hydrocephalus via external ventricular drain if necessary, seizure prophylaxis, and intensive neurological monitoring in an ICU setting are critical. Rehabilitation planning starts early, as many survivors require long-term support for mobility, speech, or cognitive recovery. Here's the key takeaway for all clinicians and caregivers. Hemorrhagic stroke treatment is a race against time. Meticulous blood pressure control, swift reversal of bleeding risks, and timely surgical intervention save brain tissue and lives. Never delay escalation to specialized stroke or neurosurgical teams when hemorrhage is confirmed. Implementation. But how does the carefully designed treatment plan come alive at the bedside? How do these life-saving interventions transition from textbook recommendations to real-world clinical action? Imagine a 65-year-old man arrives at the emergency department unconscious after a suspected stroke. Within minutes, the stroke team is activated. A non-contrast CT scan confirms a large intracerebral hemorrhage. Immediately, the protocol springs into motion. Each step deliberate, each second critical. Implementation begins the moment hemorrhagic stroke is diagnosed. The patient is transferred to a neurocritical care unit, where continuous monitoring of vital signs, neurological status, and intracranial pressure can take place. Intravenous antihypertensives are titrated carefully to reduce blood pressure without compromising cerebral perfusion. If the patient was on anticoagulants, reversal agents are administered without delay, whether that means vitamin K, PCC, or specific antidotes like idarucizumab for direct thrombin inhibitors. Platelet transfusions are readied if needed. Neurosurgical consultation happens early. The decision for hematoma evacuation or external ventricular drain placement is made based on hematoma size, location, and the patient's clinical status. If a subarachnoid hemorrhage from an aneurysm is identified, interventional neuroradiology teams prepare for coiling or neurosurgeons plan for clipping, depending on the facility's capabilities. Simultaneously, preventive measures against common complications are put into action. Prophylactic anticonvulsants to reduce seizure risk, nimodipine for vasospasm prevention in subarachnoid hemorrhage, and DVT prophylaxis to prevent secondary clot formation. Nutrition support, airway management, and early rehabilitation consultations are also seamlessly woven into care. This multidisciplinary coordination between emergency physicians, neurologists, neurosurgeons, critical care nurses, radiologists, and rehabilitation specialists is what turns clinical guidelines into life-saving bedside care. A stroke protocol is only as effective as its real-world execution. Build stroke teams, rehearse the steps, and ensure rapid access to neuroimaging and neurosurgical care. Because when hemorrhage strikes, preparation and teamwork are the difference between survival and tragedy. Monitoring and follow-up. What happens after the bleeding has stopped? When the initial crisis is over? What ensures the patient doesn't slip in a silent decline or face unexpected complications? Consider this. A patient survives a life-threatening intracerebral hemorrhage after timely surgery and medical management. The family breathes a sigh of relief. But within days, the patient suddenly deteriorates, confused, feverish, and unstable. What went wrong? A missed complication, undetected in the absence of vigilant monitoring. Continuous monitoring and diligent follow-up are as vital as the acute intervention itself. In the neurocritical care unit, the patient's intracranial pressure, ICP, neurological status, blood pressure, and oxygenation must be meticulously observed. Elevated ICP can develop silently, risking herniation and death if not promptly managed. For subarachnoid hemorrhage, the danger of vasospasm peaks between days 4 and 14. Daily transcranial Doppler ultrasounds, neurological checks, and close hemodynamic monitoring help detect this life-threatening narrowing of cerebral vessels. Seizure activity, infections such as pneumonia or urinary tract infections, electrolyte disturbances, and deep vein thrombosis are also common risks in the post-stroke period requiring proactive management. Long-term follow-up is no less critical. After stabilization, patients need structured rehabilitation plans, covering physiotherapy, occupational therapy, speech therapy, and neuropsychological support to regain lost functions. Serial imaging may be necessary to monitor for rebleeding, residual aneurysms, or hydrocephalus requiring shunt placement. Outpatient follow-up ensures control of modifiable risk factors, strict blood pressure management, adjustment or cessation of anticoagulants when appropriate, smoking cessation, and dietary counseling. Emotional and cognitive assessments help detect post-stroke depression or dementia-like syndromes that can quietly erode recovery. And here's the essential reminder for every care team and family member. The stroke journey doesn't end with hospital discharge. Vigilant monitoring, early detection of complications, and dedicated rehabilitation are the bridges between survival and meaningful recovery. Without them, even the best emergency care may fall short. Prevention of hemorrhagic stroke. Can a devastating brain hemorrhage be prevented before it strikes? Is it possible to stop the silent buildup of risks that eventually lead to catastrophe? When a man in his 50s skips his routine blood pressure checkups, dismisses his doctor's advice on diet and smoking, and ignores persistent headaches, months later, he suffers a massive intracerebral hemorrhage, one that might have been entirely preventable with earlier intervention. The truth is that most hemorrhagic strokes are preventable by controlling modifiable risk factors. At the forefront is strict blood pressure management, the single most effective strategy to reduce the risk of both intracerebral and subarachnoid hemorrhage. Hypertension silently damages cerebral vessels over time, and untreated high blood pressure remains the leading cause of spontaneous brain bleeds. Lifestyle modifications are equally essential. Smoking cessation lowers the risk of aneurysm formation and rupture. Reducing alcohol intake helps prevent hypertension and liver-related bleeding disorders. Regular exercise and weight control improve cardiovascular health. A low-sodium, balanced diet supports healthy blood pressure levels. For individuals on anticoagulants or antiplatelet therapy, careful risk-benefit assessment and regular monitoring are crucial to avoid excessive bleeding risks, particularly in the elderly or those with a history of falls. High-risk individuals, such as those with a family history of aneurysms or arteriovenous malformations, may benefit from screening imaging studies like Mr. Angiography. For diagnosed aneurysms or AVMs, preventive surgical or endovascular intervention may be considered to avert rupture. Public education also plays a role, teaching communities to recognize and act on early signs and risk factors can dramatically reduce the incidence and mortality of hemorrhagic strokes. Preventing hemorrhagic stroke starts today with every controlled blood pressure reading, every stopped cigarette, and every informed lifestyle choice. The steps we take before symptoms appear are the ones that truly save lives. Emerging trend for hemorrhagic stroke management. Where is the future of hemorrhagic stroke management headed? What groundbreaking innovations are reshaping how we prevent, detect, and treat this deadly condition? Consider this scenario. A patient arrives at a stroke center equipped with AI-powered imaging analysis. Within seconds of a CT scan, the system flags a small, previously unnoticed cerebral microbleed, an early warning sign that allows for preemptive blood pressure control and preventive therapy. This is not science fiction. It's already becoming a reality in advanced stroke centers worldwide. One of the most exciting trends is the rise of artificial intelligence and machine learning in neuroimaging. These technologies can detect subtle patterns, such as microbleeds or small vascular malformations, that may be missed by the human eye. Early identification of these risks allows clinicians to intervene before a catastrophic hemorrhage occurs. Another emerging field is minimally invasive surgical techniques. Traditional craniotomy for hematoma evacuation is giving way to stereotactic aspiration and endoscopic evacuation, which reduce tissue trauma and improve outcomes. Early trials show promise for better recovery and fewer complications. In the realm of subarachnoid hemorrhage, flow-diverting stents and next-generation endovascular coiling techniques are expanding treatment options for complex aneurysms that were once considered inoperable. These innovations not only improve survival, but also reduce the risk of rebleeding. On the prevention front, genomic research is uncovering genetic markers linked to aneurysm formation and vessel fragility. In the near future, genetic screening could help identify high-risk individuals, even before imaging shows any vascular defect. Telemedicine and mobile stroke units are also transforming care delivery. Portable CT scanners and real-time remote neurologist consultations are now deployed in ambulances in some cities, cutting diagnosis and treatment times dramatically. The fight against hemorrhagic stroke is no longer limited to the hospital walls. Technology, genetics, and early detection are shifting care from crisis response to proactive prevention. Staying informed and embracing these advances could mean catching the next life-threatening bleed before it ever happens. In conclusion, hemorrhagic strokes, whether intracerebral or subarachnoid, remain among the most devastating neurological emergencies, demanding rapid recognition, precise intervention, and long-term vigilance. Yet, as we've seen today, much can be done to reduce risk, improve survival, and enhance recovery through prevention, cutting-edge diagnostics, coordinated care, and emerging medical technologies. But awareness is the first step toward change. If this video has deepened your understanding or could help others in your circle, please like this video, subscribe to our channel, and share it with colleagues, patients, and loved ones. Together, we can spread knowledge that saves lives. And if you have any questions or personal experiences to share regarding stroke care or prevention, drop them in the comment section. We'd love to hear from you and continue this important conversation. Stay informed, stay prepared, and remember, the life you save could be your own or someone close to you.